Hi everyone, my name is Marina, and today I, along with my team members, Jude, Anya, Vicky, Joyce, and Farida, will be presenting to you the story of our patient Claire. Her story is that of a complicated clinical case, a successful diagnosis, and a look into her future. Our patient Claire is a 27-year-old woman who presented to the emergency room with a 2-week history of hematuria. We received her medical history, and the only thing of note was she had a single skin lesion biopsy that was classified as benign by her dermatologist. We also received her family medical history, and there was no indication of any cancer or other disorders, but her mother did have a hysterectomy due to unknown reasons. So based on the blood in her urine alone, we decided to do an abdominal ultrasound, and this would show common causes of hematuria, including a renal cyst or kidney stones, and the results of the abdominal ultrasound showed an isoechoic nodular formation on her right kidney. Isoechoic means possibly a tumor-like mass, so based on the fact that Claire has a possible tumor on her right kidney, we decided to order a CT to get a better look. The CT showed a 7-centimeter tumor on her right kidney, which to put in perspective is about the size of an apple. So this tumor at 7 centimeters meets criteria for the 3-centimeter rule, which states that any tumor with a diameter of 3 centimeters or greater in this area meets criteria for immediate removal. So based on this, we suggest a radical nephrectomy with wide margins to remove the tumor and also to do a cell biopsy to see if this tumor is malignant or not. Also revealed by the CT were multiple uterine leiomyomas, which are smooth muscle tumors. In fact, her uterus was largely replaced by them. And in the general population, 70% of US women actually have these uterine leiomyomas, but the extent to which Claire had them makes us suspicious that there's something else at play here, especially considering her mother had uterine issues herself. The first differential diagnosis is tuberous sclerosis complex, or TSC. This is a genetic disorder characterized by smooth muscle tumors in various regions of the body, including kidney, heart, lungs, and skin. The second differential diagnosis is hereditary leiomyomatosis with renal cell carcinoma, which we will refer to as HLRCC. This disorder is characterized by leiomyomas on the uterus and skin, and there's also an increased risk of renal cell carcinoma, which is a type of kidney cancer. So at this point, we ordered a genetic test for Claire to see if one of these disorders was present. The genetic test revealed a mutation on chromosome 1 at location Q43, which is where the fumarate hydratase gene is located, or FH. We'll go more into the pathophysiology and function of the FH gene, but for now I'll just go into the 2 diagnoses that are characterized by this mutation. So the first is fumarate deficiency, which is present in young children and infants. It's a central nervous system disorder in which you have seizures, microcephaly, and developmental delays. The second disorder, characterized by an FH mutation, is HLRCC, which we talked about in the previous slide, but as a refresher, it's a genetic disorder characterized by skin and uterine leiomyomas and putting the patient at an increased risk of developing renal cell carcinoma, or kidney cancer. Based on Claire's renal tumor, uterine leiomyomas, skin lesions, history of uterine issues, and all of these confirmed by the FH mutation, we are confident that Claire has hereditary leiomyomatosis with renal cell carcinoma, or HLRCC. We'll come back to Claire's case in a bit, but for now we're going to walk through the pathophysiology, socioeconomic, and health outcomes of this disorder.
As Marina previously mentioned, HLRCC is one of the conditions caused by a mutation in the fumarate hydratase, or FH gene. This gene encodes for the fumarase protein, which acts as an enzyme in the Krebs cycle to convert L-malate to fumarate. Research suggests that the FH gene plays an important role in tumor suppression. Individuals with leiomyomas tend to have low levels of FH expression, and 15% of patients with a mutation in the FH gene go on to develop renal cell carcinoma. This diagram here shows the expression of the FH gene in various tissues. As you can see in the red bar, the kidneys have one of the highest expression of the FH gene. In the context of HLRCC, the FH gene undergoes an autosomal dominant germline mutation, which prevents the formation of a full fumarase tetramer. HLRCC tends to be related to a variety of missense mutations, and the disease is thus likely related to the dosage of the gene rather than the location. As such, there is no genotype-phenotype correlation. So how does the FH gene relate to tumor development? Fumarate accumulation due to a loss in the FH gene prevents degradation of HIF-alpha, as it is the competitive inhibitor of HIF-alpha hydroxylases. HIF-alpha, which is depicted as the yellow boxes in the diagram on the right, causes the upregulation of genes involved in responses to hypoxia, which have effects on cell growth, proliferation, angiogenesis, glycolysis, and tumorigenesis. Loss of the FH gene also prevents oxidative phosphorylation, which further promotes aerobic glycolysis, which is the most common method of metabolism used by cancer cells. Fumarate also promotes oxidative and electrophilic stress responses. Normally, the NRF2 transcription factor, which is represented by the dark blue boxes in the diagram, are constitutively pressed and degraded. In patients with HLRCC, fumarate inactivates the repressor. NRF2 is then allowed to cause the transcription of genes that offer protection for cancer cells from oxidative and electrophilic stresses, and then increase the rate of glycolysis. Now that we have examined the pathophysiology of HLRCC, Jude will introduce some of the potential treatments that are options for patients with HLRCC, such as Claire.
Thank you, Joyce. So you've established that HLRCC manifests itself in Claire and other patients in several ways: benign skin lesions, uterine fibroids, and renal cell carcinoma. These have separate specialized treatments. Skin lesions, also called cutaneous leiomyomas, are often painless, and in these cases, we generally leave them alone as surgical excision tends to leave behind substantial scarring. A minority of patients do develop symptoms of smooth muscle pain, and in these cases require surgical intervention. As Marina mentioned, uterine fibroids do occur in the general population. However, in HLRCC patients, they appear earlier in life and proliferate extensively. Similar to skin lesions, uterine fibroids are generally left alone unless they proliferate to the point of affecting fertility, in which case we perform a hysterectomy or a myomectomy. Because of the aggressive nature of the carcinoma associated with this illness, surgical excision of primary and secondary tumors is necessary. So in Claire's case, Marina's recommendation of a radical nephrectomy would have been the course of treatment regardless of the 3-centimeter rule. Several clinical trials are currently underway to investigate alternate forms of treatment. For example, botulinum toxin A for the treatment of the skin lesions, and bevacizumab and erlotinib for the treatment of the renal cell cancer tumors. HLRCC has been reported in 300 families worldwide, making it quite rare. But the actual number is predicted to be much higher, probably because these symptoms on their own seem unconnected, and they are not likely to be attributed to an underlying illness in a regular checkup. Because HLRCC yields a high risk of infertility and aggressive cancer, it's essential to have more thorough screening procedures earlier in life for children with a family history of this disease. This includes genetic testing and frequent skin exams and MRIs from an early an age as 2. So to recap, Claire has HLRCC, a genetic disorder characterized by leiomyomas and increased risk of renal cell carcinoma. This fumarate hydratase mutation only confirmed our diagnosis. And fumarate hydratase, when mutated, promotes tumorigenesis through abnormal HIF-alpha and KEAP NRF2 pathways. HLRCC is rare but vastly underdiagnosed, making early and frequent screening the best course of action. So, what does this mean for Claire? First things first, immediate surgical excision of primary and secondary tumors found. Next, consult a gynecologist to see if a hysterectomy or a myomectomy is necessary in her case, and inform her about the associated risk of infertility. And we want to do another more thorough skin exam to examine all skin lesions. Since this is a hereditary illness, her family members must undergo genetic testing too. HLRCC, with its associated medical costs, hospital visits, infertility, and cancer risk, is not an easy one to bear. In this time, it's important to make sure that Claire and her family members are supported and well informed. Fortunately, organizations like the HLRCC Family Alliance provide easy to access and understand information and a welcoming support community for Claire. As Marina introduced in the very beginning, Claire's case has taken us through a difficult diagnosis, a daring treatment strategy, and finally a hope for the future. On behalf of Mighty-chondria, thank you for listening. If you have any questions, please feel free to reach out.